Welcome to Putting Rare Disease Patients First, Webinar 009, the ADCs of Clinical Trials for Blood Cancers. I would like to extend a warm welcome to everyone that is in this webinar. Before we commence our presentation, I will give some instructions for the webinar. Please silence all noise-making devices. It is important that we keep all background noises to a minimum because the webinar will be recorded. You may wish to mute your telephones until you are ready to ask questions at the appropriate points. I am very pleased to introduce Dr. Lorna Speed as our chair today.
Thank you very much, Leanne. I'd like to add my welcome to everyone on this webinar. This webinar has been recorded because we intend to make it available to many patients and carers, advocates, and parents of children with these types of rare cancers. My name is Lorna Speed, and I'll be the chairperson for today's webinar. I'm founder and president of Putting Rare Diseases Patients First. I'm joined by a very special guest, Dr. Mohrbacher from USC, and I'll introduce Dr. Mohrbacher shortly. This slide shows the outline for today's webinar. I'll be giving you a little bit of information about the nonprofit called Putting Rare Diseases Patients First. I'll explain a little bit about why we do what we do. There'll be a disclaimer. I'll give you a little bit about my background, and then we'll go into the main presentation. We're really focused on finding out about blood cancers in relation to the clinical trials that are being run for them, and especially the current state of the art in terms of the treatments available for blood cancers. I'll give a brief introduction into clinical trials. We covered clinical trials in a lot of detail last week for webinar 008, and today I'm really going to focus on the two key types of clinical trials for blood cancers. And then I want to give you let you hear some patient stories, and we'll talk about what you can do as a patient or parent. Putting Rare Diseases Patients First was formed in January of 2014, and during 2014 we became a formal nonprofit. We do seek to have a global reach. We've had parents and patients on the webinars from many different countries, and we have a direct-to-patient strategy because we know that knowledge is power, and we are seeking to give the patients and the parents the information they need that it would be otherwise very difficult for them to access. And we talk about the diagnostic process for rare diseases. We speak about the drug development process. We speak about the clinical trial process in particular. We cover areas such as natural history studies and patient registries as well. These are the areas of key importance to parents and patients with rare diseases. Today we're focused on blood cancers, but we have covered many other subjects as well. We cannot give medical advice about your specific medical situation. We will discuss questions at times that are discussed in generalities that are important for many different patients and parents, and not just any specific cases. So to give you a little bit about background, I'm a clinical pharmacist registered in the United Kingdom. I did a special PhD in safety assessment of medicines pre and post marketing, which was an industry PhD. I have experience in the development of new medicines, including for several blood cancers. I've worked for 3 large pharma and 3 biotech companies. I wrote a book about clinical trials for patients and healthy volunteers so they would be able to ask the right questions and understand the clinical trial process. Webinar 009 was made possible by a grant from Pfizer Pharmaceuticals, but Pfizer have had no influence at all in the development of this content. So let's get into the meat of our presentation today, ABCs of clinical trials for blood cancers. Here you can see a schematic or presentation of blood flowing in the bloodstream. And we can see many different components. We see the red blood cells, we see lots of other components as well. And we're talking about blood cancer, and the blood system is a relatively complex system, and this shows some of the components that might remind you of your biology lessons at school. When we speak about blood cancers, we're speaking about the three main types, the leukemias, the lymphomas, and the myelomas. And Dr. Mohrbacher is going to talk about that in more detail. We're really focused today on the types you can see when we speak about what are the names of the blood cancers: ALL, AML, CLL, CML, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and multiple myeloma. And here I want to speak about the new medicine development process for blood cancers, many of which are relatively rare. Before commercialization, new treatments have to go through a new medicine development process, and this is a complex process, but it can be broken down so that we can understand the key components as it relates to this topic we're discussing today. It's like a maze, but again, it can be understood in an appropriate way. One of the key things about cancers and life-threatening diseases is that the regulatory hurdles are lower for the development of new treatments. And so it's a shorter process for getting new treatments through the process, and there is a little bit less to do than in many other disease areas. The clinical trial process consists first of finding an appropriate dose. How much drug do we need to give, in other words, to get the effect that we want? The effect that we want is a safe new medicine, and a medicine with the effect that helps to bring the blood cancer into remission or get rid of it completely. So as we go through that process, we've divided the drug development process, and particularly the clinical trial process, into phases. In phase 1, we are looking for the dose. We're also wanting to make sure that the amount that we're giving to the patient, i.e. the dose, is safe. And these are patient studies usually. Sometimes we call them phase 1/2 studies. When we go into phase 2 proper, we are looking to make sure that the dose is also not just safe, but effective as well. We call that efficacy. We're also trying to make sure we've identified the best patients for those studies. Depending on the patient population, if there are no other treatment options, we can actually seek registration or approval at the end of phase 2. And then we would continue with our development in the post-marketing phase or in the commercialization phase in phase 3 studies. There are times when we need to go into phase 3 studies, especially if there are other treatments for the patients. We would go into phase 3 studies. These can be survival studies. So these are looking at the survival of the patients, and they are comparative studies, looking at the comparison with the treatments that already exist. So phase 1, phase 2, and phase 3. The two key types of studies I want to talk about are the studies where we compare with the standard of care. So standard of care means that we do have some other treatment options for the patients, and we're comparing the study drug against the standard of care. And the ideal design is to randomize the patients against the standard of care, the study drug against the standard of care. The randomization process involves using statistical concepts and tools that help us to, in a non-biased way, put patients evenly between the study drug and the standard of care. Because if left to our own devices and we knew the patients, we would be more likely to put some in the study drug and some in the standard of care, and we wouldn't get an even study that would not be biased, and the study results would not be valid, as we call it. So randomization against the standard of care. And standard of care is often what patients have already gone through, they may have failed at standard of care, or they may not have had the best response. And so often we have to find a way, if possible, to put patients on not just the standard of care, but also the study drug as well. Otherwise, sometimes patients decide they don't want to continue in the study. And the patients do have the choice. They do have the right to make that decision for themselves. The other type of study design is the open label clinical trial design. In an open label design, we do not know, it's not a blinded design, it's just open label, so there is no blinding, and then it may not even be a different study group, so the patient may just be in one, all the patients are in one study group receiving different doses perhaps, but it's not blinded in any way, and it may not even be randomized. There may be a comparison group as well, so the open label can also apply to the randomization approach. Often it's unethical in this type of disease area to give a placebo, and it can also be unethical to compare with already failed standard of care. So this is where we receive these one group and we're finding a dose and everybody's receiving that same dose or a set of doses, and everybody knows who's receiving what. Some recent proposed changes which would be very helpful for some patients who have traditionally been excluded from clinical trials in the cancer area are to include children in special groups, and also to include patients with liver dysfunction, heart dysfunction, and kidney dysfunction. Traditionally, these patients have been excluded from the clinical trials. Also to include patients with HIV, HCV, and HBV. And this is proposed, these changes are proposed by the FDA. To include patients with brain metastases as well. Approximately 70,000 patients are diagnosed with brain cancer every year. And if these patients could be included in traditional clinical trials, perhaps we might find more approaches for treating brain metastases. So at this time, I'm very pleased to introduce Dr. Mohrbacher.
Hi, my name is Ann Mohrbacher. I'll be talking about the medical aspects of some of the blood cancers and the treatments we're trying to develop for them. I originally trained with the tumor immunology group at the Dana-Farber Cancer Institute at Harvard and have been at USC for 25 years doing clinical care of patients with lymphomas, Hodgkin's, multiple myeloma, and the other blood cancers we're going to speak about today, with a little focus on immunotherapies and stem cell transplant. So in this compressed time, we can't go into great detail about each individual disease, but I'll do a little overview, and I'd like to point out that when you have one of these cancers, it's best to go to the patient advocacy websites such as the Leukemia Lymphoma Society to drill down into much more information and latest treatment options specific to your disease. And we're in fact thankful to the Leukemia Lymphoma Society for using some of their basic slides for this teaching purpose. So as you know, we think of our blood system as the cells in circulation, but it really is also our immune system is comprised in the blood system. And blood circulates between the marrow, the lymph nodes, which are a parallel system to our blood system, and the spleen. And we know that although we term them blood cancers, they really are cancers of any part of that system. In fact, we put a fair bit of emphasis on the bone marrow, and we often refer to stem cell transplants by the older term bone marrow transplants, because that is where most blood cells really originate from and are born and developed into the more mature, differentiated, or specialized cells. So when we say the word stem cell in our field, we're really referring to blood stem cells, which were the original stem cells we understood. And they live in the niche of the bone marrow and grow up into two families, the myeloid lymphoid families, which then grow up into further specialized cells like red cells that carry your oxygen for you in the bloodstream, platelets that clot your blood when you have a wound, and all the rest of the cells are the white blood cells. And those really are what you refer to as your immune system. There's several different types of white blood cells. They have very sophisticated and specialized jobs and interactions. They're very much like a very sophisticated military system that is arranged to defend you against infections and also against cancer. Your immune system is important for defending you against cancers, particularly blood cancers. So as you see in this family tree of blood cells, you have neutrophils, which are sort of the infantry that do the hand-to-hand combat against bacteria and infectious agents. You have natural killer cells. They're like the Army Rangers or Marines that go in and kill particularly cancer cells. That's why they're called natural killer cells. The T lymphocytes, or T cells, which organize and run the immune system like the generals. And the B cells, which provide antibodies as sort of the weapons of the immune system, helping you fight off bacteria and other agents that you've been vaccinated against. And when they're committed to a very specialized program, they grow up into a cell called a plasma cell. And we know we have cancers of each of these different white blood cell types that can affect your immune system or grow into an overgrowth of a cancerous process. So we really don't know what makes them do that. In some cases, there might be an infectious trigger, but we don't really know what that trigger was once the cancer cells have grown out. Probably a great proportion of blood cancers grow out because of some random genetic damage to a cell somewhere in that stem cell or family tree. Particularly the leukemias, we see evidence of genetic damage and sometimes even a prior exposure in life that would have caused that genetic damage. But some of that just occurs with the wear and tear of life. White blood cells are some of the most rapidly growing cells in your body, so they're copying and dividing each day, and they're a little more prone to make a mistake in copying their DNA and developing a new mutation. So these mutations are not something that was inherited from the parents, but acquired during life, later in life in general, which is why most cancers, including blood cancers, are seen at older ages. But they do occur in children, and some of the most common cancers of children are the acute leukemias, ALL. So we know that certain specific environmental exposures, like very high dose radiation, not usually, just diagnostic radiation from x-rays or something, but very high doses of radiation, such as being near an atomic bomb site, having had therapeutic radiation, for example, for another cancer, can occasionally cause blood cancers like leukemias or myelodysplastic syndrome. We do know that certain petrochemicals, benzene and so on, are suspected in terms of contributions to creating new cancers of the blood system. We also know that certain infections are triggers, specifically to the lymphomas. Helicobacter pylori, Epstein-Barr virus, some very unique viruses that cause certain T-cell leukemias have been direct triggers, and a more distinct association even with the hepatitis viruses. We also know, conversely, that people who have suppressed immune systems, such as patients with HIV or AIDS, people who are on agents to suppress their immune system for lupus or rheumatoid arthritis or inflammatory bowel disease, or a very big group of patients who are on immune suppressants for their kidney transplant or liver transplant, are prone to developing skin cancers and lymphomas in particular, because the immune system and the T cells, which are being suppressed by those drugs, are important for patrolling the body and killing off little upstart cancer cells. And we do know even some of the cancer therapies we use for other cancers occasionally themselves cause DNA damage. Fortunately, at a very, very minor rate, but in a way that can even trigger blood cancers in particular. So first, let's just do a very broad overview of the incidence and types of blood cancers, and we'll start with the leukemias. There are 2 chronic leukemias and 2 acute leukemias, each of the 2 big families I showed you in the blood cell family tree. So on the lymphocyte side, we have chronic lymphocytic leukemia, which is in fact the most common cancer leukemia out there by prevalence. It's not very common by new cases per year, but people live a very long time with CLL, often never treating it during their lifetime, up to a third of patients, because it's just there in the background and not necessarily causing them much disease complications. On contrast, if it develops in an earlier lymphocyte, the acute lymphocytic leukemias are called acute because they develop abruptly and have dangerous complications from the beginning because these cells grow very rapidly and take over the blood system. So they're not very common, but we have many more survivors than we used to have. We might just have 2,000 or so new cases in adults or 2,000 in children per year, but people are living longer with this disease and surviving it. So many of these numbers of prevalence would be people who are already cured of the disease and surviving it. The chronic myeloid leukemia patients have a very specific targeted therapy developed years ago by Brian Drucker and are often on just oral agents, keeping that disease completely under control without needing any chemotherapy or stem cell transplants in general. That's been a great success and an important illustration of why we have clinical trials for blood cancers. And finally, the acute myeloid leukemias, again, that word acute meaning it's explosive, rapidly growing, life-threatening. And this is generally a disease more predominantly in older individuals and adults with variable success, but a lot of new targeted agents that make this an exciting area of promise for treatment of blood cancers. So we'll just go briefly over these with the very basic slides, again, from Leukemia Lymphoma Society about what the general nature of these diseases are. Acute lymphocytic lymphoblastic leukemia, called either way, it's nicknamed ALL, it's less of a mouthful, occurs in the bone marrow and spills over into the blood. Is generally traditionally treated and cured in many cases with chemotherapy. But the same chemotherapy that would cure 85% of children with this disease will it only cure about a third of adults. So we know that we have to go on beyond that and look for other agents or even stem cell transplant to cure the higher risk children or the adults. We do special preventative chemotherapy into the spinal fluid. We often add pill or oral agents that target a specific gene called the Philadelphia chromosome that is mutated in a small percentage of children and a larger percentage of adults with ALL. And very often we have to consider a bone marrow and now called a stem cell transplant in higher risk children and adults with ALL to really cure the disease, because our goal is always cure. There's no living with this disease in partial response. So we generally are using peripheral blood transplants, which we'll talk about later in this disease. We also have the acute myeloid leukemias, or acute myelogenous leukemias, nicknamed AML. These are generally mostly diseases of adults and older adults. They're very related to random mutations that occur in early stem cells in the bone marrow and grow out into a malignant population of cells. And again, like ALL, it's treated with chemotherapy, usually a first round to induce remission, as we call induction, and then several courses of therapy afterwards, almost all inpatient, very intense and dangerous chemotherapy, often concluded or consolidated with a stem cell transplant. The acute leukemias are generally treated with transplants from other people or allogeneic transplants, which we'll hear about later. The other diseases we'll talk about, the lymphomas, Hodgkin's, myeloma, are usually treated, if needed, with stem cell transplants from the patient's own stem cells or autologous stem cell transplant. So again, in the acute leukemias, we have to really use very intensive and complicated chemotherapy for cure, but we're making new progress in targeted therapies and even immunotherapies for these diseases. Now, CLL, by contrast, is at the opposite end of the spectrum. It's a very unaggressive disease in most individuals. Many of them are diagnosed later in life, incidentally, because they're having a blood test for screening for surgery, or they have a gallbladder surgery and they find some lymph nodes in there that are taken out and examined under the microscope. And this is really not a disease of fast-growing or aggressive cancer cells, but of accumulation of cells that are accumulating in the bone marrow and then the blood and often lymph nodes. They're originally supposed to be B cells that would make antibodies to fight infections, but they don't really do that job functionally, and they just grow in an uncontrolled but rather gradual fashion in the bone marrow and blood and eventually lymph nodes and spleen. It's often not treated during the patient's lifetime, but it's just sort of a chronic disease that has to be managed. But if it does grow to the point where it's crowding out red blood cells or platelets in the bone marrow, causing anemia or bleeding problems, low platelets, it does have to be treated. And this is an area of blood cancers where really clinical trials have totally changed the type of treatment. It's rather uncommon to use conventional chemotherapy anymore in CLL, and we generally go right to the newer targeted and specifically oral agents along with monoclonal antibodies. And we'll talk about that in a little bit. So it is a very common leukemia if you just look at prevalence, because it is a disease that people live with for a very long time. It's typical for people to live 10 and even 20 years with this disease. And there are some patients who are diagnosed at younger ages, even below 50 or 40, but does not particularly behave more aggressively. It just is more concerning because they have a normal life expectancy and are wondering when they will need to intervene and treat that disease. The most common blood cancer of all, though, are the non-Hodgkin lymphomas, about 70,000 new cases in the U.S. per year, with a very, very wide range of pathology subtypes that really range from being very unaggressive disease like CLL, the lymphoma equivalent being small lymphocytic lymphoma, SLL, to very aggressive diseases like Burkitt's and high-grade or double-hit lymphomas. And if you have this diagnosis, you really want to drill down into the specific pathology type you have and go to your patient advocacy websites and learn more about that with your specialist treating you, because the treatments are very much tailored to those subtypes. So the lymphomas arise from lymphocytes, as you could gather, either B or T lymphocytes, predominantly B lymphocytes, that originate often in lymph nodes and tissues of the body and grow in that area inappropriately because of some mutation that tells them to stay turned on and reproducing. And they multiply gradually or rapidly out of control and start to fill up the lymph nodes and create masses. It's very common for a patient to be diagnosed because they feel a lump under their arm or in their groin or on their neck, and that leads to a biopsy revealing lymphoma. But we do have lymphatic tissue throughout the body. Occasionally you'll see lymphomas that involve the stomach, the intestines, spleen, skin, or bone marrow. And the biopsies from those sites lead to the diagnosis. So overall, lymphoma is the 6th most common cancer in men and women in the United States. There's slight variation of types of lymphomas throughout the world and by ethnicities. Most of the cases are in adults. It's quite uncommon in children, and the incidence increases with age. So finally, the other major cancer type we'll talk about, and I'll use as an illustration of some of the principles of blood cancers, is multiple myeloma. And this is a cancer of plasma cells, a very specialized type of B lymphocyte that are supposed to produce antibodies for you, that lives almost exclusively in the bone marrow. So it's really defined as a cancer of the plasma cells, and they produce this antibody that's often detected as a monoclonal protein in the blood. The cells themselves are found almost only in the bone marrow, and they start to spread throughout the bone marrow and turn on bone remodeling cells that cause what some people in other cancers would call bone metastases, but really destructive spots or soft spots in the bones, say of the rib, the skull, pelvis, or shoulder, and can cause fractures of those areas. And often it's very common for a myeloma patient to present with bone pain. They step off a curb and have pain in their back or their leg, or they sneeze and have a painful rib, and that leads to an x-ray that determines that there's something abnormal there and leads to a biopsy. And sometimes they show up because they've developed anemia or high protein in the blood that leads to workup of a bone marrow biopsy to show this cancer in that location. So it is generally a disease of older individuals like CLL. It's skewed towards the older individuals over 60, 70s, and 80s. It's slightly more common in males and females, and per capita more common in African Americans and other ethnic groups. But in general, it's treated approximately the same across all these groups. And we've probably seen the most dramatic improvements in survival and quality of life in multiple myeloma relative to all cancers. It's been very gratifying in the 25 years that I've worked in this area, because we've really moved away from very difficult and symptomatic chemotherapies towards much, much more elegantly targeted agents through the use of clinical trials, many of which I've participated in this disease over the years. So why do we talk about the bone marrow so much? As I mentioned earlier, the bone marrow is where all blood cells originate, and it is often the home where many of the blood cancers reside. So the word myelo is Greek word for marrow, Multiple myeloma almost exclusively lives in the bone marrow. The myeloid leukemias live there. The ALL and AML leukemias originate and predominantly reside there. The myelodysplastic syndromes and myeloproliferative disorders all reside there too, because it's basically the home base of most blood cells normally, and also of many blood cancers. Many lymphomas will involve the bone marrow, and it is common to do a bone marrow biopsy in all of these blood cancers. We'll occasionally skip it in some of the lymphomas where it's less likely to be there. So what do we see when we're looking for a blood cancer under the microscope? We'll see where these arrows are drawn, these cells that seem larger or more numerous than normal. We would normally only have like 1 or 2% plasma cells in our bone marrow, and here this patient has several. We can tell they're a little bit larger and more activated. We also might see, if we were looking for leukemia, sheets of very big cells that are called blasts, that are the cancerous cells of the ALL or AML that we're looking for. And we can send a liquid sample of that bone marrow to a special test called flow cytometry that will test it for 20 markers, for example, to tell us it's a B cell or a T cell. And it's a young cell, might be ALL or AML, or it's a plasma cell and it's multiple myeloma, or specific markers that tell us it's CLL or mantle cell lymphoma. So the bone marrow is often very important and very right to the point with that flow cytometry for giving us a diagnosis. We'll also send those samples for special genetic tests that will tell us what specific mutations not only tell us what the disease is, but what we can target with our specialized therapies. Very important in the acute leukemias and to some extent in prognosis in myeloma. So, as you've heard already, in many of our diseases, the primary approach is classic chemotherapy agents. I would say the hardest chemotherapy agents, of course, are the leukemias, where the patient's often inpatient, very intensive chemotherapy, wipes out their blood system and their immune system along with it, creating dangers for them. But those chemotherapies are curative, which is why they're justified. But we are still looking for more targeted therapies, particularly for cases where we know there will be resistance by the specific mutations or genetic changes we see in the cancer cell. So chemotherapy is still the backbone in most of these diseases, but we are moving away from it in the diseases where we have more elegant or targeted therapies, such as CLL, where classic chemotherapy may really be going by the wayside completely. And we're getting halfway between that with many of the lymphomas and even multiple myeloma, where chemotherapy per se is less important than some of the new agents that are more elegantly targeted or immunotherapy oriented. On the other far end of the scale of chemotherapy, we have the stem cell transplants, which are really either the allogeneic transplants for the acute leukemias, where we use very strong chemotherapy and radiation to try to wipe out the leukemia cells and kill off much of the immune system with it, and we replace it with somebody else's blood and bone marrow system in the allogeneic transplants, versus the autologous transplants in myelomas and lymphomas and Hodgkin's, where we're really just trying to kill off the cancer cells and give some fresh stem cells from the patient's own supply that we've collected ahead of time back to them to restart their blood system and grow it back in a week or two. So we'll talk a little more about stem cell transplants, but you can see that's very non-selective, sort of very brute force approach of use of chemotherapy, but it's still very important. It has a strong curative benefit in most of these diseases. In between that, though, we've really developed over the years more and more selectively targeted therapies that look at a pathway that the cells are very dependent on, such as ibrutinib and CLL, the BTK pathway, or a mutation that is specific to that cell's survival and why that cancer survived, such as the BCR-ABL inhibitors, tyrosine kinase inhibitors, and CML and ALL. And we keep trying to develop more and more targeted therapies as we learn more about the specific mutations and genetics that drive each of these diseases. We also have had a great benefit from immunotherapies. The monoclonal antibodies are mainstay of the treatment of all the common lymphomas, which are predominantly B-cell lymphomas, the anti-CD20 antibodies. And more recently, we've developed antibodies for multiple myeloma with derivatumomab or anti-CD38 antibodies. So they are now combined frequently with chemotherapy and lead to synergistic effects between the chemotherapy's efforts to kill the cancer cells and the immune system's efforts to kill the cancer cells, so they don't have a chance to recover or grow back. But most important, we learn about all these new therapies by doing clinical trials, which we'll come back to at the end. Also, in the blood cancers, the high-grade lymphomas, for example, might have one active phase where the patient feels a node, gets diagnosed, gets treated with chemotherapy for 4 or 5 months, and they're done. They're cured. True of Hodgkin's, the high-grade lymphomas. But many of the blood cancers are really chronic and not necessarily curable. So using this graph as an example of multiple myeloma, much like CLL, much like low-grade lymphomas, there will be probably a pre-existing phase where the disease wasn't even known. It was living in the bone marrow or quietly in some lymph nodes. And then it grows and becomes evident either by anemia or growing lymph nodes in the case of the lymphomas, or something changed in the blood, and it's recognized as active disease. So in the case of myeloma, we recognize the active myeloma. We go back and treat them with, in the old days, chemotherapy. In these days, much more selectively targeted therapy agents. We bring it into remission. We try to often maintain them in that remission with active therapy of maintenance, and eventually they become resistant to that and relapse again. We treat them with different agents, bring them back to remission, so on through multiple courses of therapy. A patient who's lived 10 years with myeloma or low-grade lymphoma might have had 3 to 8 different therapies and gone into remission or partial remission during many of those periods in between. So that's the pattern of the more chronic blood cancers, and trying to find better agents or ones that are more tolerable to stay on for maintenance, to draw those remissions out to longer years, is also a very important goal, not just cure. But in many of these diseases, stem cell transplant is still the definitive or most important consolidative therapy. So in Hodgkin's lymphoma or the high-grade non-Hodgkin's lymphomas, if patients aren't cured by their frontline therapy, and we do have very, very high success with classic chemotherapies and the monoclonal antibodies together, curing many of those lymphomas, a majority of them, in their first-line therapy. But if they come back or relapse, Hodgkin's and the aggressive non-Hodgkin's lymphomas are treated with patients are treated with high-dose chemotherapy and autologous stem cell transplant. In acute leukemias and in some of the lymphomas that have very high relapse rates after first-line therapy, we might even predict that they need to go to transplant right at the end of their primary couple months of chemotherapy. In the case of leukemias and the myeloproliferative or myelodysplastic syndrome, that bone marrow or stem cell source will need to come from another person. In this picture, I'm just illustrating how blood stem cells are collected, whether that is from the patient for an autologous transplant or from a sibling or another donor for an allogeneic transplant. And it's a procedure that is identical to how one would donate platelets at the Red Cross. There are 2 lines, and blood is taken out through one line, flows through the system, is spun in a centrifuge, and white cells are collected in a transfusion bag and saved for later, and the rest of the blood is returned. So it's a continuous flow, closed, sterile system. Not particularly uncomfortable. I've done it. Anybody who's donated platelets at the Red Cross. So we do want to encourage those of you who are interested in being a donor for other people or family members to consider this is not a particularly hard thing to do, and is generally preferred to doing bone marrow collections for transplant now. The stem cell process is going to be explained in a little more detail in the upcoming video here.
Otherwise, a higher cure rate. Stem cells can be obtained from either the patient themselves or from a tissue type matched donor. In general, using the patient's own stem cells is called autologous stem cell transplantation and is mainly used for patients with lymphoma or for multiple myeloma. For patients with leukemia, we tend to use donor stem cells. The source of stem cells can either be a brother or sister. There's a roughly 1 in 4 chance of any brother or sister being a tissue match with the patient. If the sibling is not a match, then we can find alternative donors from either unrelated donor volunteer banks, and there are now over 25 million people worldwide who are potential donors on those banks. More recently, we've been using half-matched family members. So that would mean that any parent or any child of a patient would be half a match. And therefore, we're much more likely to find donors for almost every patient we look for nowadays.
So I don't want to overemphasize stem cell transplants, but they clearly have been a big part of our improvement in survivals in blood cancers. And the International Blood and Bone Marrow Transplant Research Group, CIBMTR, tracks this throughout the world in terms of transplant success. And in this slide illustrates how we've made incremental improvement even by 4- and 5-year intervals in our overall impact on survival in multiple myeloma, which is in fact not cured by stem cell transplant, but we know that we can probably prolong life along with our newest agents, bringing out those remissions to longer term. And similar improvements have been seen in several of our blood cancers in which this is used. So it's the combination of better use of chemotherapy, better targeted agents, immunotherapies, and stem cell transplants that has led to the dramatic improvements across the blood cancers over the decades. And as this LLF slide shows us, we've really more than tripled and even quadrupled survival in some diseases. Myeloma, perhaps the most dramatic. From the 1960s to the 2000s, the increase in survival at 5 years has improved from 12% to 43%. And now it's very typical and not uncommon to see patients living 10 and 15 years with myeloma. Hodgkin's lymphoma, we always did quite well in, but we still more than doubled the survival in that. We really don't need to use stem cell transplant very often because we have very effective chemotherapy that works in curative fashion in this disease. Similarly, in non-Hodgkin's lymphoma, we've had improvement, not so much by stem cell transplant, although that's always our backup curative option, but by the addition of monoclonal antibodies to these therapies and better immunotherapies and targeted agents. And finally, in leukemias, very dramatic improvements, mostly due to stem cell transplants and allogeneic transplants, but some incremental improvement now, even though the chemotherapy hasn't changed much in 30 years, with targeted therapies that are really going to improve the outcomes in that disease. And we're very excited about those developments. Well, blood cancers are cancers of the immune system, and many of our approaches that have been very successful in this area have been immunotherapy-based. And they started with the monoclonal antibodies. Big breakthrough, and I was very happy to work in this area in my training and then on into my faculty work with monoclonal antibodies against CD20, which marks the vast majority of lymphomas, and in fact, more than 80% of all blood cancers originate from the B cell family, which expresses this marker. And the antibody rituximab brings immune cells to the cancer cell and targets it for killing by natural killer cells and macrophages and cells that have receptors for that. So this can really synergize with chemotherapy, which damages the cell and knocks it down, knocks the tumor cell down, and then the immune cells come and finish it off. So it's been very important in the lymphomas and CLLs to combine monoclonal anti-CD20 antibodies with the chemotherapy or pathway inhibitors that we use now. We also use them as sort of a vehicle of targeting a toxin or a radioactive molecule to the cell. So agents, radioactive molecule was added to the back of the antibody, and then it was used to deliver it to the tumor cell selectively. And years ago, we tried to use this to deliver toxins, so sort of a magic bullet type approach. It wasn't very successful 20 years ago, but people didn't give up on the concept, and we'll see in some slides coming up how we've now developed better linkers that have allowed us to bring antibody-drug conjugates, selectively bringing the chemo just to the cancer cell and causing very little toxicity in other areas of the body because of that targeted fashion. So here a general cartoon with one of the first successful developed antibody drug conjugates. So bringing a magic bullet, a chemotherapy drug only carried into the specific cell by an antibody targeting by a marker on that cell, Blinatumomab being the first successful example of this, targeting CD30, which is found on Hodgkin cells and many T-cell lymphomas, anaplastic lymphomas. So the antibody comes and binds to that surface marker, CD30. It's then internalized into the cell where the linker between the chemo agent and the antibody is dissolved, and that releases the chemo agent just inside the cell and kills the cell from the inside out. We wish we had this approach for all cancers, but it really is based on whether there's a good marker to target an antibody to and whether those cells can take that marker internally to kill the cell. So we have Blinatumomab in the CD30 positive Hodgkin's and anaplastic lymphomas and some T-cell lymphomas, and new antibody drug conjugates are in development right now for myelomas and lymphomas and acute leukemias. Very, very exciting area with very focused use of chemo with less toxicity to the patient. Another approach is to take an antibody to pull the immune cells that kill cancer cells closer to them. T cells and natural killer cells are our main killer type, or cytotoxic cells. So the use of a two-ended antibody or bispecific antibody, Blinatumomab being the first and very successful example of this. The front end of the antibody binds CD19, which is found on most B cells, but also on the very early B cells of acute lymphoblastic leukemia, or ALL. The back end of the antibody, like a two-ended plug, plugs into a marker on T cells, or CD3. And this is the first successful bispecific antibody called a BiTE antibody, bispecific T-cell engager, that was active in ALL, has been FDA approved for acute ALL, and also more recently approved for very early use, even when there's very minimal disease found, 1 in 10,000 cells still remaining, called MRD, where you can use that antibody at its best advantage, where it's the highest opportunity of really clearing those last straggler or resistant leukemia cells. So this has now become a main therapy in ALL to get patients cleared all the way to the cleanest bone marrow possible and on to their transplant in many cases to have successful cure. It's also being tested in some other B-cell cancers such as lymphomas. Probably the most sophisticated or complicated immunotherapy now, though, is the use of the CAR T cells. There's been a lot of press and media about this, where we take the patient's own T cells, take them outside the body, and genetically transfect them to force them to better recognize their own tumor cells. So again, using that target on ALL cells and lymphoma cells of CD19, we force some of their T cells to genetically to recognize, by genetic engineering, to recognize CD19 positive cells, and also have a co-stimulatory signal to make them activate and go out and find and kill those leukemic cells. So it's a complex process. It requires a couple weeks. The cells have to be collected from the patients, transfected, and then given back to the patient in their new modified form to go seek out and kill those cancer cells. Been tested in CLL originally, where it first made the news. It has been FDA approved in ALL and now in aggressive refractory non-Hodgkin's lymphomas, and has been quite successful. I have my own patient who's now been in a 3-year remission from a CAR T-cell treatment of his aggressive and relapsed non-Hodgkin's lymphoma that had failed even after a stem cell transplant. And finally, a very broad category of agents that have been effective in many cancers, including lung cancers, have really been brought to bear with great success in blood cancers, particularly Hodgkin's lymphoma, and these are the immune checkpoint inhibitors. These agents look at how cancer fools the immune system and stays alive and hides within our body. And many cancers have a system using PD-1 and PD-L1 receptor on them that basically tells the T cell to ignore them, sort of hypnotizes the T cells to forget about them. And you can break that hypnotized action by using anti-PD-1 or anti-PD-L1 antibodies. And so these are called checkpoint inhibitors. And their big news in many solid cancers. It turns out they're incredibly effective in Hodgkin lymphoma, where the overall response rates can be 50 to 85% or so. They're very well tolerated, and in fact are moving up into earlier use in Hodgkin lymphoma. They work even in patients who failed transplants and all other available therapies in Hodgkin's. And I have several patients who've been on them even for a couple of years with no further activity of their disease. So a very exciting area for immunotherapy, starting to replace many classic chemotherapy agents. We still need our workhorse chemo agents that are very successful and curative in many of our blood cancers, and part of the curative approach of stem cell transplants, autologous or allogeneic. But we are hoping to make more elegant targeted therapies and immunotherapies that spare some of those toxicities of the chemotherapy agents, and we're certainly achieving that in many areas of blood cancers today.
Thank you very much, Dr. Mohrbacher. This is a very helpful and hopeful presentation on the state of the art of treatments for blood cancers, and it's good to hear that patients are able to look forward to less aggressive treatments and even more effective treatments, and that are more tolerable than they've been in the past. Tell us a little bit about your practice at USC.
Okay, so as I said, I trained in the tumor immunology group at the Dana-Farber, and our interest there was finding the markers that identify blood cells, but also how could we target them. And it's very gratifying to see some of the things that were in very early development when I was young, now in mainstream use and a big part of the curative and life-prolonging benefit of our treatments of the blood cancers I treat. So I have a particular emphasis originally on multiple myeloma, but more generally on all the B-cell cancers, lymphomas, Hodgkin's, multiple myeloma, CLL, but in the broader practice treat leukemias and myelodysplastic disorders as well. And so my interest was always in immunology. How does the immune system work? Why do these blood cancers develop from the immune system? And my original work was with the monoclonal antibodies, and it's very gratifying to see what a huge impact rituximab has made, Rituxan, on survivals in lymphomas and CLL, and I, of course, use that every day, and it was part of the original investigators with many others in the development of that. We worked for many years on vaccine trials. We didn't get very far with that in the blood cancers, but I still have hopes that some of the knowledge that we gained from those trials will come back to fruition. I've worked predominantly with the stem cell transplant programs. In my group, I oversee the autologous stem cell transplant program. So that's mostly for myelomas and lymphomas and Hodgkin's. Very, very interested in cellular-based therapies, particularly allogeneic therapies and CAR T-cell programs. And I've also been involved in a number of trials with antibody-drug conjugates and new antibodies and bispecific antibodies. So I've participated in dozens of trials, and it takes a lot of mental fortitude to realize that many of these drugs won't come to productive use, but I've certainly been part of the trials for rituximab and bortezomib and derivatumomab and other antibodies used in the diseases that I now use every day in the treatment for our patients, and they're much less toxic than some of the chemotherapies I used in my training. So it's very gratifying to see those come to fruition and see them become mainstream in the diseases I treat. And I have to stop and pause and thank all the patients and their supporting families that participated in those trials, because in many cases it benefited them, but certainly benefited many other patients after them by bringing those drugs through their development till their availability for patients at large now. So I do want to encourage everyone to listen carefully why it's worthwhile to look at clinical trials and participate in them.
That's excellent. Good answer. Good encouragement too. What types of blood cancer patients would refer themselves to you or be referred by their physicians? Are you treating patients who have failed other treatments, or may they be early in their disease?
Well, multiple myeloma, very often patients are referred to me early in their disease because we commonly consolidate their primary first 4 to 6 months of treatment with high-dose chemotherapy and autologous stem cell support. It's a very simple stem cell transplant. You know, it's still not fun. It's 2 weeks in the hospital to feel like a very bad flu. But it does seem to really reset the time clock on the disease. And my patients have lived 10 and 15 and long 20 years have mostly been those that went stem cell transplant. The Hodgkin's and non-Hodgkin's lymphomas are sent to me if they relapse after their first-line therapy, because the stem cell transplants are highly curative in them. 70 or 80% will be cured by autologous transplant. Some of the other lymphomas that have very high relapse rates, 80% or higher, are also sent after their first 4 or 6 months. So those patients are sent because we know, what the transplant may hold for them. But I am sent a lot of patients who are looking at clinical trials. They have failed 2 or 3 or 4 different therapies, and we have clinical trials for lymphomas and some for myelomas and some for many different trials for leukemias. And they are hoping to find something that will work when their disease is resistant. So certain diseases we're so successful with that we wouldn't even offer a clinical trial till they had failed, 1 or 2 things. I had this conversation yesterday. There's still very good treatment, has a 80-90% response rate, and it's easy. As already FDA approved agents will say, no, go do that first, and if that doesn't work, then come back and we'll talk about trials. Other diseases have such poor prognosis that many of the AML patients will offer them a clinical trial right from their first treatment, because we know they have a difficult looking prognosis, and we have new agents that would give them perhaps a boost in that initial effort to get into remission.
Is combining, people are so afraid of chemotherapy, they hear the horror stories, is combining chemotherapy with targeted approaches when possible, making the treatment with chemotherapy more tolerable? Yes,
and in many diseases, completely replacing the chemotherapy. So CLL patients, as of even just this last year, we're seeing that the new oral agents and the monoclonal antibodies are as good or better than any chemotherapy was, and generally much less risky. On the other hand, I have to really put the brakes on people sort of assuming all chemotherapy is harsh. The chemotherapies used, for example, in multiple myeloma are generally not very harsh, except for the transplant itself, which is a very brief treatment. It's an investment, I tell people, in their future. They're spending 2 weeks feeling pretty sick from this really strong chemo, but it might give them years of further remission. So it's a trade-off. Other chemotherapy used, for example, in non-Hodgkin's lymphoma is not necessarily very harsh. Getting completely cured by 4 months of a chemo that many people will still be able to work through and travel and do their social activities is a good trade-off. So you have to look at the risk-benefit. If it's a high cure rate, like ABVD in Hodgkin's and RCHOP in diffuse large B-cell lymphoma, 4 months of chemo, 80%, 90% cure in some of the best risk groups, the common risk groups, that is very worth it. It's not very harsh and very high cure rate. AML, sometimes we tell people, the chemo just isn't worth it. It's very harsh, it could kill you, and this particular circumstance, it may only have a 10% chance of curing you. So we're going to suggest you do a trial or do demethylator agents instead, which are much more full or at least more specific to your disease. So it really has to be looked at with hematologic oncology specialists to tell you what is really the risk and benefit. Don't lump chemotherapy too broadly, because some of it is easy, some of it is hard, some of it has a very high cure rate, and it's very worth the toxicities, the short-term toxicities, and others. Toxicity is worse than the cure rate benefit, and it may not be worth doing. And that really is what your specialist, your oncologist is there to discuss with you.
Thank you so much. Very helpful. As we close out with you, can you tell us a little bit about your research? Where do you see this field going?
Well, I'm very focused on the immunotherapies, but I think now we are very much heading towards the use of cellular therapies, where we either modify the patient's own immune cytotoxic or killer cells, such as CAR T cells, or we create immunotherapies that will help bring their immune cells to the target cells, and also even using other people's healthy immune cells to give to the patient when their immune system just can't do the job for them. So there's a lot of very exciting work with what we call off-the-shelf cellular therapies, where we're trying to have other people's sort of pre-programmed, pre-primed immune cells ready to go to give to the patient. So I'm always interested right now in the upcoming antibody drug conjugate trial in myeloma. We're getting ready to do some very unique CAR T-cell therapy trials and participating in some very unique immunotherapies, hoping for more outpatient treatments and more selectively targeted.
Well, thank you very much, Dr. Mohrbacher. I know you're extremely busy, so we'll let you go right now, but we appreciate you taking the time from your busy schedule to tell patients about the state of the art of treatments in blood cancer. Thank you very, very much.
You're very welcome.
Thank you. Now we're going to watch 3 patient stories. We've heard about the state of the art, and now we'll go to some patients and hear their experience of these blood cancers. The first is non-Hodgkin's lymphoma. These are patients from the UK.
I never had any health issues. I never went to the hospital except to have our 3 children, and was actually kind of shocked and in sort of disbelief when I got my diagnosis, non-Hodgkin's lymphoma, large B-cell. Our oncologist educated us about what it was and said, you know what, you're going to go through chemo and you're going to get through this. And I said, okay, that's what I'm going to do. For a couple of years was cancer-free, but then I relapsed. And that's when they said, well, okay, then the next step for you would be a stem cell transplant. First clinicians or the people who keep tabs of clinical trials said you need to look at something called CAR T. CAR T is where they take your cells out of your body, then they send them into your body, and they go right after the cancer. It is a clinical trial, and it doesn't work for everyone. There are no guarantees, but when your options are limited, it seemed like the best course for me, and thankfully was blessed to be able to do it at the Cleveland Clinic, which is reasonably close to home for me. One of the researchers said to me, Marybeth, you have to not think of yourself as a patient. You need to think of yourself as a pioneer. And that really had an impact on me in terms of, okay, so this is scary, and there's no guarantee that it's going to work, but it might work, and it might assuredly work in the future for somebody else.
Without a clinical trial, nothing gets approved. And so you need to have people willing to step up and take the gamble. You can feel their empathy. You know that they're on this journey with you, and they want you to succeed.
I've had 3 PET scans already since my treatment, and they've all shown I was cancer-free. As long as you can find somebody who knows something about this and can lead you in a path that may be in your best health interest, then you need to push forward. You need to keep moving, and we would always say, as long as we keep moving in a forward direction, we're going to tackle this. Molly, I'm 58, and I live in London. I'm an artist, mother of 3 sons, and I was diagnosed with CLL in 2006. The diagnosis came about because I kept getting flu symptoms, and every time I'd get on a bus or the tube, I'd get ill. So sort of the gap between getting ill and being well was getting shorter and shorter. And my husband got really fed up with it. And everyone was thinking I was a hypochondriac because I was constantly ill. And then my husband called the doctor because I was too weak to actually get down to the surgery. The doctor was young and enthusiastic, and he gave me blood tests as well at the same time. And then he kept calling me back for more and more blood tests, but he wouldn't say leukemia. And then eventually I was sent off to the blood clinic at the hospital, and the consultant just said, well, about this illness you have, and that was the first I'd actually been told that I had it. So it was a really devastating way of finding out, really. And then he didn't tell me anything about it. He said, go home and look it up on the internet. So I spent those horrible weekends finding out, that what my prognosis was, which was not very good. And yeah, it was not a good way to find out. So now I think I would question it and say, I'd like to have SCR, not SC alone, because it's a longer remission. But then at that time I was much more polite, and I didn't. I assumed everybody knew what they were doing, and I was just the patient. I decided to change hospitals because, well, it wasn't a CLL specialist hospital. It was just hematology department at the first hospital, which was basically my closest hospital. But also the way that they told me about my diagnosis, I didn't really have any confidence that it was just very upsetting. In terms of my treatment options, when it became more obvious that as my white cells were going up, I'd have to start chemo at some point. I was reading about all sorts of treatments on the website, on the CLL Topics website, but those weren't being mentioned in terms of my treatment options at the hospital. It was almost as if I was reading way ahead. The consultant was so busy dealing with what was happening that I had more information. Up-to-date information, and plus it was all globally happening. I didn't question the fact that I was offered maybe a treatment that was 2 years old or something. Now I think I would definitely insist on finding out why I couldn't have that, and if there was a reason. I just assumed it was something to do with my genetics or me personally. When my white cells started to double really quickly, I was told that I'd have to start chemo the first time. So that was 2 years after diagnosis. That was all by a pill at home. Some people are able to carry on working, and people react in very different ways to chemo. I found it completely wiped me out, and I couldn't even get to the other side of the bedroom. It made me very weak and feel very sick. But I was talking to somebody at a conference, at a CLL conference, and he had not had a day off work with his chemo, the same chemo, and yet he was a teacher. So it was people do react very differently. The tiredness, that can be a difficult thing. So sort of having to have a nap in the afternoon, and it's not as if you choose to have a nap in the afternoon. You can't argue with it. You have to just stop and lie down. That does tend to kind of, you can't make plans, and then because your body is going to do its own thing, and so you have to kind of work around it, and then maybe when you've got energy, really use that. Initially, I told lots of people, and which I really regret telling them. They didn't react very well, and people kind of write you off as that's it. So they sort of either treat you with kid gloves, or they don't want to talk about the subject at all, or they just stop inviting you. And it's difficult. It's really difficult. So if I was to do it again, I would definitely limit the number of people I told. During chemo, I found having people coming in from the outside world and talking about their lives and life going on as normal was really helpful. I think you have to find your support wherever you can. Whoever's good at one thing, maybe not good at another thing, and family to take in the diagnosis. I think my sons found it particularly difficult because they weren't able to share it or to express how they felt. And I think men have to be strong and not show their feelings. But it would come out in other ways. Yes, I'm very hopeful about the new drug being trialled at the moment, much more intelligent, targeted drugs. I'm hopeful that if I can stay alive long enough and healthy, then I'll be able to benefit from them when they're available after the trial's finished. If I was to go back now and have a diagnosis again, I would do it very differently. For instance, I would want to have somebody with me to receive a diagnosis, because it's a huge blow to be told you have an incurable disease and you only have a short time to live. Is it really kind of difficult to live with, even though that might not be true, and you might have a longer lifespan? It's still, when you're told that's very difficult to take on your own. I would definitely be much more proactive in my treatment. I would ask for treatment and ask why things were happening, and I would want to know exactly what options I have. I would definitely be much more vocal, and to know that I know what's going on and how much energy I have and how ill I feel and everything. It's really not down to the health experts or anyone else. You are your best patient advocate.
Nigel Deeks, 49 years old, just coming up 50 next year, so the big one, which will be quite interesting because of my illness and where I could have been at being 50 years old against where I am going to be. Diagnosed when I was 45, feeling very fit and well, no idea at all that I was ill, playing squash actively 3 times a week. I have noticed some weight loss, but that was a Brucey bonus. Diagnosed by flashing in my eye. And I'd had detached retina about 15 years previously, so I thought, well, I better go to the hospital because there was a good chance that I'd done something to my eye again. Went up to Birmingham Eye Clinic and went in, saw somebody, did what I felt was a cursory blood test, and had a phone call back a couple of hours later saying, go to the hospital in the morning. So went in with thought detached retina, following morning diagnosed with chronic myeloid leukemia. Taken him first appointment, 9 o'clock, sat down, and they told me pretty well outright, we think you've got chronic myeloid leukemia, which came from a very high white blood count. I was around 145, my count, against a normal count, which would be between 3 and 10. I didn't get upset, didn't do this, that, and the other, just spent about an hour talking about treatments that were out there. The first night, very, very upset. You want to see your children grow up, you want to walk your daughter down the aisle, you want to be there. They're 12 and 15. You think, are they going to remember you if you die? And I remember the first night sort of waking up, 3 in the morning and being very upset. Who wouldn't be in those circumstances? I spoke to a couple of people at Leukemia Care first of all. I wasn't sure whether the treatment I was receiving over that first 3-4 months I'd made the right decision either. But that's how my relationship with Leukemia Care came in, and the support and help they gave me. If I go back to the first day I was diagnosed and lying in bed and actually thinking, thank God I got it, because it's easier as the patient to have leukemia than it is as the family or the carer or the wife or the children, because you would take that leukemia from your children in a moment. I decided to set up a group on Facebook, which is CML UK, which is a UK-based CML support group, because a lot of the information is almost too informal out there, and I felt that there was something needed to be able to, for people to be able to speak informally, to just chat about how they feel that day, about leg pain, about the drugs, about side effects of the drugs, through the management of leukemia care, and all the predominantly, I find the most benefit is when people are scared witless, as I was in those first few days, weeks, etc., where you just think, I'm going to die, I'm going to leave my family, I'm going to leave my children, etc. And I think the ability to go on there and say, I'm new, what's happening, am I going to be okay? And for hundreds of people to come back and say, actually, yeah, you are. You know, for the vast majority of patients, life will go on very, very well. You will live a normal life. You will see your children grow up.
So I hope that you find these patient stories helpful and hopeful. There is a lot of hope, as we've heard throughout this presentation today. Many new treatments are coming through, and the treatments that we do have now are becoming more tolerable. So what do you do now? I think it's very important to educate yourself if you're the parent or the patient about your specific blood cancer, because knowledge is power. Medical journals, patient foundations, looking for specialist physicians in the appropriate hospital sites is very important. Speak to other patients, maybe even start your own patient support group or parent support group. Clinical trials can be found on clinicaltrials.gov. This is a US-based site, investigative site with lots of different trials. The reason it's so important for international sites as well is because often you will see the countries where other sites are based, not just in the US. So if you search for your blood cancer in clinicaltrials.gov and you find a number of different clinical trials ongoing, once you find the one you might be interested in taking part in, you can see if there is a site in your country. And what do you do if your child has been diagnosed with a blood cancer? Obviously, ensure your child is being treated by a specialist. And this is really important because if the hospital does not have specialists for the disease area, as we heard from one of the patients in the stories, they were being treated by a physician who wasn't necessarily a specialist in their disease. And so you've got to find the appropriate location to take your child to. And connect with the patient group, foundation, register your child in a patient registry if it's a very rare form of the blood cancer, and certainly join a parent support group. And especially importantly, stay up to date in what's happening in the disease area because new treatments are coming through all the time. And this is for the people in the US, and we heard about leukemia care in the UK, for instance, and many different countries also have their own equivalent patient foundations and disease support groups. For the US, it's www.lls.org/publications. They've created some very helpful content for blood cancers. This is the Leukemia and Lymphoma Society. And then my book on clinical trials is available in the library. It's also available in many hospital institutions in the patient libraries because Oxford University Press donated a lot of the books to the hospital sites, not just in the US, but also in the UK. And you can ask for it to be made available in your hospital or in your library. Our board of directors, just to say a little bit about our organization, is consisting of Leanne Samuel. You've probably been connected with her on social media, particularly Twitter and Facebook. We do now have Instagram as well. We'll be ramping up our outreach through Instagram and Twitter. And Dr. Karel Petrak is in charge of fundraising, and I'm the founder and the president. We have a website. We'd like you to join our mailing list on the website, take our survey. We have a Facebook page, and these addresses are here. Take our research survey. Our research survey is going to help us to provide this information in a publication so policymakers and even funders can see what's happening in the rare disease space. And it just tells us a little bit about you. We anonymize the data will never share any of your identified data about yourself specifically, but cumulatively, information about many rare disease patients and parents is going to be extremely helpful. It also helps us to raise money from funders like Pfizer, who've supported us in this effort, to make these webinars free of charge to parents and patients. And take our post-webinar survey. This webinar survey will be available, and you can take it at any time once you've watched this webinar, and we will be able to see your thoughts and your feedback. I wanted to leave you with some helpful Leukemia and Lymphoma Society contacts, and they've been very helpful in helping us to get the word out to their patient constituents. So now I would like to ask Leanne to close us out. Please help us to spread the word about our organization to your patients, your parents, and your patient constituents about what we're doing. We're really trying to help patients to get access to information that it would otherwise be difficult for them to access. And this is a direct-to-patient strategy, and it's actionable information that hopefully even from watching today, you can see some specific things that you can take action on for your disease or your child's disease. So I have great pleasure in handing back to Leanne to close us out.
I wish to thank everyone for participating today. We will be sending you information about the upcoming webinars we will have. We will send information about the next webinar by Facebook, Twitter, Instagram, and emails. Link up with us on these platforms. Please spread the word to patients with rare diseases and parents of children with rare diseases. This concludes the webinar 009. Thank you for attending.
Thank you, everyone.